Welcome. I'm Diane Lavinia, the Director of Industry Relations at the IDSA Foundation. Thank you for joining us as we celebrate CMV Awareness Month. Today's non-CME webinar, Infection Prevention, Cytomegalovirus in Post-transplant Patients, is part of the Dr. John G. Bartlett Memorial Education Series. Special thanks to our sponsor and industry partner, Takeda. Before we dive into the presentation, it's important to note that the webinar is being recorded for your convenience. You can find the recording on our website, idsafoundation.org, or on our YouTube channel. So if you need to step away or want to revisit any part of this session, it will be readily accessible. All participant microphones are muted. If you have questions or comments during the webinar, simply utilize the Q&A button to share your thoughts. Our team will be monitoring the questions and we'll have a dedicated Q&A session with our speakers following their presentations. Now I'd like to introduce Dr. Michael Eisen. Dr. Michael Eisen completed his internal medicine residency and general internal medicine fellowship at Oregon Health Sciences University in Portland, Oregon. He then obtained his Master of Science in Health Evaluation Sciences and did his Infectious Diseases Fellowship at the University of Virginia. He undertook additional training in transplant infectious diseases at Massachusetts General Hospital and Harvard Medical School under the mentorship of Dr. J.A. Fishman. He joined the faculty of the Divisions of Infectious Diseases and Organ Transplantation at Northwestern University Feinberg School of Medicine in 2005. After 17 years as a professor in the Divisions of Infectious Diseases and Organ Transplantation at Northwestern University Feinberg School of Medicine, he moved to become the Respiratory Disease Branch Chief within the Division of Microbiology and Infectious Diseases at NIAID, NIH. He also currently serves as the Editor-in-Chief of Transplant Infectious Disease. Dr. Eisen?
Thank you for the kind introduction and for the opportunity to chat with you today. Next slide. So here are my disclosures. Most of these took place at Northwestern before transitioning to NIH. All but my up-to-date work have discontinued as of effective December 4th. And it's important to note that my comments today are my personal comments, not reflective of NIH. Next slide. So CMV is quite a challenge. It's something that many of us become infected with. Oftentimes in our teenage years, it becomes latently infected in a wide range of tissue, including vascular endothelium throughout the body, including vascular endothelium of the transplanted organ. It remains latent, but produces proteins that are virally mediated. And some of these interact with the host immune response, particularly when anything triggers TNF-alpha release. This results in a cascade of events that phosphorylates NF-kappa B, trimerizes with two viral mediated proteins, and results in viral replication. Things can upregulate this, particularly concomitant use of things like steroids, as well as cytokines produced by the infected cell in a paracrine fashion. CMV causes a wide range of clinical diseases, including the direct effects of the virus on any of the organs that it may affect. Generally, the most common organs affected are the transplanted organ and the gut in our transplant population. CMV syndrome is the most common presentation where you have low-level viremia, oftentimes with neutropenia, as well as fatigue, myalgias, and fevers. There are a number of indirect effects that are mediated through a number of different mechanisms. These can cause upregulation in the risk of other opportunistic infections, activation of other herpes viruses, as well as increase in host immune responses to the allograft, resulting in both acute and chronic rejection in these patients. Next slide. The burden of CMV disease really was quite significant prior to the advent of prophylaxis, as was shown here, particularly among those individuals that were seronegative with receiving an organ from a seropositive donor. Nearly 100% of patients would go on to develop CMV replication, with many having end organ disease. With the era of prophylaxis that we'll get into in a few minutes, we've been able to markedly reduce the risk of CMV in most patient populations down to somewhere around 12 to 16%. Next slide. The one thing that I will mention is that even in the setting of D minus R minus, where the donor and recipient are seronegative, there is a low persistently positive risk of developing CMV, with about 2% of patients developing CMV, either from a false negative test, from infection through transmission through contact, such as with other infected individuals, or through receipt of things like unselected blood products. Camille is going to get into the use of CMV immunity, but one major risk factor that has been identified, in addition to being seronegative, meaning that you don't have protection against CMV and receiving an organ from a donor that is CMV positive, that in those patients, even if they are CMV seropositive themselves, there's variability in the degree of CMV specific immunity. And those patients that lack this CMV specific immunity are at higher risk of developing CMV infection, as well as relapse of infection once treated. This can be measured in a number of different ways. The two most commonly used approaches are with either the ELISpot or the ELISA type methodology, although more flow-based tests are available in selected settings. Utilization of these will be discussed more by Camille. Next slide. Once you have a clinical suspicion that the patient may have CMV, and whether that's just a low white count or fever in the patient, we need to use diagnostics to identify whether the patient has infection or not. On the left-hand side is kind of the oldest school that we've got, and that's cell culture. And you can see these cytomegalic cells kind of in the middle of the picture. These are not terribly sensitive. They're useful for things such as CMV pneumonitis, but oftentimes, even if you inoculate blood from a patient that with very high viral loads, may not give you this result. As a result, and again, a historical approach was to use PP64 staining. This is where the neutrophils would phagocytize the virus and virally infected cells, and staining of PP64 generated from the CMV would stain positive. You can see that those bright green are cells that are affected or that have phagocytized CMV infected cells. The challenge with this is if someone's neutropenic, this lacks sensitivity, and you need an experienced provider to be able to look through and identify these, particularly when there's very low viral loads. Next slide. This has resulted in most areas utilizing PCR-based diagnostics, in which you're able to really get very sensitive tests. Some of the tests go down to just 2 digits, 37 or 30 copies per ml, which is incredibly sensitive. Initially, these tests did not have a WHO standard, and as a result, each lab developed their own test, and you would get an incredibly broad range of results. And in fact, up to a 2 to 4 log difference if you compared results from one lab to another, which really made it quite challenging to interpret results if you had CMV testing done in multiple different laboratories. Next slide. Fortunately, the WHO came up with a standard, and the best example of how effective this was are the 2 graphs on the left-hand side. This comes from Switzerland. Each site is a different transplant center in Switzerland. As you can see in the far left, the The patient, the centers had a wide range of results when you compared samples across each of the different sites at different viral loads. Again, about 1 to 2 log difference depending on which hospital was running the test. When all of these labs switched over to a single assay, in this case developed by Roche, that used a WHO standard, you had a much more linear approach, and the results were generally the same from center to center. Again, mild variability, but this allowed places like Switzerland to be able to have a patient that lived in Geneva, but was cared for example, in Zurich, have the test locally and be able to have that interpreted by the team at a distance. Despite this standardization, there still is some degree of sample and assay-specific variation. The graph on the right-hand side really shows a number of different assays using the same standard, and you can see that if you have one assay and compare it to another, you may have, again, up to a log to 2 log difference between the two. So again, if you're sending a patient out and following their CMV at a local lab, you need to understand what assay are they using? Is it the same or different from the test that is being run in your hospital, so that you don't inadvertently think that the viral load has gone up or gone down when the opposite is the case. Next slide. As I've mentioned, there's a number of different forms of CMV disease. CMV viremia without symptoms really is something you don't see very often. Oftentimes patients may think that that's the case, but when you start asking them, have you been more fatigued or had some aches and pains or fevers, they'll say, oh yeah, I've noticed that. And sometimes they will notice it even more once they get treated and start feeling better. More common is CMV syndrome, where patients have fever, neutropenia, and viremia detected, or DNAemia in this case, and then end organ disease. And as mentioned, this can be any organ, including the transplanted organ. There are some sites, such as the gastrointestinal site, CNS, and the testes. If you have replication in these areas, you may have a low or undetectable CMV viral load. And so that's really important for us to think about. If you have a patient presenting with significant diarrhea that is just stopped his valganciclovir prophylaxis and is having some fevers and not feeling well, even if the CMV viral load is negative, you would want to do a colonoscopy to make sure that the patient doesn't have local disease, since about 15% of patients with CMV colitis may have low or undetectable CMV viral loads when tested. Next slide. Prophylaxis, like many challenges in transplantation, is the mainstay of our approach to preventing CMV disease in these patients. This can be done in a number of ways. It starts by screening of the donor and recipient. Some areas, particularly out west, are trying to do serum matching to help reduce the risk of CMV D plus R minus, the highest risk population. Likewise, blood screening can be helpful, again, particularly in those patients that are CMV negative, donor and recipient, to either use leukoreduced, that's taking out most of the white cells that may have CMV, or using CMV negative blood. Active immunization is an area where there's been a lot of progress, and hopefully we'll have an intervention that can help our patients. But for now, it still remains experimental and is not widely available. Passive immunization with immune globulin, either polyclonal IVIG or CMV hyperimmune globulins, are available and actually were the mainstay of prevention prior to the development of antiviral therapy. Antiviral strategies can fall into a number of different approaches. Universal prophylaxis, when all at-risk patients receive antiviral therapy for a fixed duration of time. Preemptive therapy, where patients get tested serially, and when they test positive, they receive therapy to help suppress the CMV and then take them off, or a hybrid approach in which they have universal prophylaxis and then switch them at some later time point to preemptive therapy, all of which have been tried. There are pros and cons to each of these approaches, as is outlined in the table on the right. The clinical efficacy, they both are very effective in preventing CMV. Ease of application really is center dependent. When I first got to Northwestern, we were a preemptive monitoring center, but we found that we missed a lot of screening and had a number of breakthrough cases. And when we switched to a more universal prophylaxis, it was much easier for us to implement and had lower rates of CMV. Again, different centers may have better capacity to monitor the testing. Late onset CMV is more common with the use of universal prophylaxis. Drug toxicity, since you're exposed to the drug for a longer period of time, is greater with antiviral therapy. And then there was some data suggesting that there may be worse kidney graft outcomes with preemptive therapy. And both strategies are associated with risk of antiviral resistance. Next slide. So the first attempt to really study modern therapy to prevent CMV was this study in high-risk transplant recipients in which they were randomized to receive oral ganciclovir, which was not terribly bioavailable, or oral valganciclovir for about 3 months. And as you can see at the end of the treatment arm, the valganciclovir arm was about a third that of CMV infections compared to the ganciclovir arm, showing that it was superior. But when you looked out to a year, about half of patients ended up needing to be treated for CMV. Additionally, in this study, there was a higher rate of tissue invasive disease in liver transplantation, which led to preferential the black box warning suggesting not to use this, although it is still a common practice to use prophylaxis even in the liver transplant population. Next slide. Because of this high rate of CMV at 1 year, a follow-on study was performed in the high-risk D+R- kidney transplant patients, in which they were randomized to receive either 3 months in the blue line or 6 months of valganciclovir in the green line. And as you can see, you had about a halving of the risk of CMV at the 1 year mark, from 37% to 16%. Rejection rate trended to be higher among the shorter prophylaxis arm. So again, great benefit for longer prophylaxis in this high-risk population, but we saw more leukopenia in the longer duration of therapy. Next slide. Historically, up until very recently, really our only option was to use valganciclovir and oftentimes either give lots of GCSF or take them off prematurely, risking the development of CMV. Literally just a week or so ago, the data was published on letermovir, a newer class of antiviral that doesn't have the cytopenia side effects of valganciclovir. As a result of this study, letermovir was approved for the prevention of CMV in the transplant population, solid organ transplant population, as it had been approved earlier for the prevention of CMV in the stem cell transplant population. Basically, there was no difference in the frequency of CMV disease or investigator-reported CMV disease between the two arms. But as you can see on the right-hand side, that there was much lower incidence of development of neutropenia or leukopenia with the use of letermovir. And so while we're waiting for updated guidelines, I think most are using valganciclovir for prophylaxis when universal prophylaxis is being considered. This is given for 3 months for patients that are R+, unless they've received lymphocyte depleting antibodies, with a longer course of 6 months in those patients receiving lymphocyte depletion and or D+R-. In patients with problems with neutropenia or side effects from valganciclovir, I think letermovir will become the kind of second-line agent to switch patients to for those having problems with valganciclovir. Next slide. But one issue is do patients need universal prophylaxis at all? And really, this landmark study in liver transplantation patients was done by Nina Singh, in which she randomized patients to either preemptive therapy or antiviral prophylaxis. And as you can see, there was a statistically significant higher rate of CMV at 1 year in those patients that received antiviral prophylaxis favoring preemptive therapy. And CMV-specific immune therapy was consistently higher for both CD4 and CD8 cells throughout the preemptive therapy arm compared to antiviral therapy. And so for liver transplant patients, preemptive therapy, if that can be safely performed at your center, is probably the best approach for prevention of CMV. Next slide. And with that, I'll turn it over to Diane.
Great. Thank you so much, Dr. Eisen. Now I'd like to introduce Dr. Camille Nelson-Cotton. Dr. Cotton is the clinical director of the Transplant and Immunocompromised Host Infectious Diseases Program in the Infectious Diseases Division at Massachusetts General Hospital and an associate professor of medicine at Harvard Medical School in Boston. Dr. Cotton has served as the chair of the Infectious Disease Community of Practice of the American Society of Transplantation. She has also served as the president of the Transplant Infectious Disease section of the Transplantation Society, and highlights of her time as president include development of 3 versions of the International Guidelines on CMV Management after solid organ transplant, published in Transplantation. She is the first transplant infectious disease specialist to be a counselor of the Transplantation Society. Dr. Cotton's clinical interests include cytomegalovirus vaccines, donor-derived infections, zoonoses, and travel and tropical medicine in the transplant setting. She is a member of the CDC Advisory Committee on Immunization Practices and is involved in the national decisions regarding COVID-19 and other vaccines. Dr. Cotton.
Thanks very much. It's such a pleasure to be with you all today. I'm talking about one of my very favorite things, CMV. Next slide, please. Next slide. I have a few potential conflicts as outlined on this slide. Next slide, please. So let's start talking about treatment. Next slide. So treatment of CMV infection, as Mike very nicely outlined, is actually pretty straightforward. So once you've made the diagnosis that you either have CMV syndrome, asymptomatic viremia, or end organ disease, it's pretty straightforward. First, I would recommend determining the severity of the infection. And if it's mild to moderate disease, as showed in the Victor trial, you can certainly use oral valganciclovir. The standard dose is 900 milligrams twice a day, renally adjusted. If they do have clinically severe disease, ophthalmologic disease, retinitis, colitis with severe malabsorption, or resistant refractory disease or life-threatening disease, then we do recommend intravenous ganciclovir, 5 milligrams per kilogram every 12 hours, renally adjusted. Although we do say in the CMV guidelines that we can readily convert to oral therapy once they are clinically improving. We also recommend reducing the immune suppression as possible. That's in close conversations with the transplant team. And if they have hypogammaglobulinemia or if they have severe life-threatening disease, we often recommend the use of CMV immunoglobulin in that setting. We would then recommend going on and checking a weekly CMV, either viral load, or technically the real name should be DNA-emia. So it's the amount of CMV-related DNA in the bloodstream, because we don't actually know if it's live or dead virus in the bloodstream. And as Mike nicely outlined, use one diagnostic platform and don't change, and then one type of specimen, either plasma or whole blood, and stick with that one. Otherwise, you'll see a lot of variation in test results, and it'll be really confusing. I see a lot of misdiagnosis of resistant refractory disease because of changing of specimen types or platform. And then we recommended in the guidelines trending the results weekly until there are either 1 or 2 negative or very low test results. By very low, because we have these ultra-sensitive assays now, we often don't get people completely to negative. So very low is reasonable, and then stop therapy. And just to highlight that if the CMV DNA-emia doesn't fall after 2 to 3 weeks, think about resistance testing. Don't send it just at 1 week. We often see a bump at 1 week, an increase at 1 week, and then a fall by week 2 or 3. So don't worry. I just got 3 emails yesterday about this, about the viral load going up at 1 week. But that's why we don't like the expression viral load. It's actually DNA-emia, and you often would think that if you're killing something, maybe you'll have a lot more DNA in the bloodstream. Next slide, please. Here is table 7 from the guidelines, and this just goes over the best dosing based on renal function for ganciclovir and valganciclovir. And this requires very careful calculation over time. It can be really hard to know the true renal function of a transplant patient. People tend to just glance at the computer calculated result, but with low muscle mass and sometimes a single kidney transplant, those numbers might not be correct. So definitely put a lot of thought into dosing. And if you do, you'll have less resistance and then less toxicity from drug. Next slide, please. So one of the big issues we see is what to do with very low viral load cases. Should we be treating all of these patients? And by very low, I mean sort of less than 500 to 1,000 IU per mil on plasma or whole blood. Treatment isn't always indicated. A lot of times our immune systems will actually be able to clear this on its own. So things I think about when I'm deciding whether or not to treat would be, what is the net state of immune suppression? What is the likelihood that there'll be a severe disease flare worth waiting? What is our ability to do repeat testing reliably and make sure that the patient comes back for that? And then what are risk factors for severe infection? And it's really important to understand the issues with diagnostics at the very low results. With real-time PCR, some of those may even be false positives or really not significant. Retesting in a week is key with these cases, just to make sure that they're not getting a lot worse. And it approaches to this very widely among clinicians. I do think a lot of people are really over-treating, and we need to formalize guidance there. Next slide, please. So I put together this grid mostly for myself, and then I shared it with some of my fellows, and then I find that the fellows are often taking pictures of this slide, in that it tells you which antiviral agents cover which viruses. And one of the important teaching points is that we've been, as Mike nicely outlined, we've been using a lot of valganciclovir over time, which covers pretty broadly for the human herpes viruses. And my teaching point would be that letermovir and maribavir are CMV specific agents. So if you are using them either for prophylaxis or treatment, if your patient's sick enough to get CMV, they're probably sick enough to get disseminated zoster. So you may wish to have a cyclovir in the equation. But just to really emphasize the point that with these new drugs, they just cover CMV and they don't cover as broadly as some of the other agents. Next slide, please. So how can we predict the risk of recurrent infection after treatment? And this remains a major issue because we do see high rates of relapse. Next slide, please. So Dipali Kumar put together a very interesting small trial where she looked at 32 patients who needed treatment for viremia. And half of them, she gave standard treatment. And at the end of treatment, half had a positive quantiferon CMV, so positive T cell immunity for CMV. And the other half had a negative test result. And as you can see in the lower left, it was a mixed population of high risk D plus R minus at 44% and 48% were seropositive. Next slide, please. And what she was able to show is that people who had a positive quantiferon at the end of treatment stayed CMV free. One had a bit of a relapse, asymptomatic disease that did not require treatment. That's why that blue line on the right is not entirely straight, but not clinically significant, did not require treatment. But of those with a negative quantiferon, she actually gave 2 additional months of antiviral prophylaxis. But when that was stopped, 69% developed CMV infection. So this is actually really helpful in that it really lets you know who perhaps you don't need to focus your attention on and then who you do need to focus your attention on. Unfortunately, those with a negative quantiferon or an indeterminate quantiferon remain highly problematic for management because we don't really know what to best do with them. Next slide, please. So one of the things I really like is at the end of treatment, you can look at their absolute lymphocyte count. Many of us don't have ready access to either T-spot CMV or the Virapore assay or quantiferon or any of the others. So if you don't have access, just look at the absolute lymphocyte count. We all have access to this. I actually made a dot phrase in EPIC. And you can see that if they have a very low absolute lymphocyte count, less than 600, that their hazard ratio of CMV relapse is over 11. And if they're in the sort of 700 to 1500 range, the hazard ratio of relapse is 5.8. And if they're above an absolute lymphocyte count of 1600, that was very unlikely to relapse. Never say never, but pretty much they don't relapse. And so this for me has been super helpful in that I know to whom I may wish to give secondary prophylaxis or additional monitoring, or who is likely to stay free from CMV. Next slide, please. So what about treatment of resistant refractory disease? And this has been a hot topic because we have some new treatment options. And this is also one of the most problematic and data-free zones, and often involves very chronically ill, quite immunocompromised patients. Next slide, please. So risk factors for resistant virus include inadequate antiviral drug dosing or delivery, prolonged antiviral drug exposure, ongoing viral replication, strongly immunosuppressive therapy, and use of drugs with a low barrier to resistance, where Letemavir has the lowest barrier to resistance in the setting of replicating virus, not with prophylaxis, but with ongoing infection, followed by Maribavir, followed by the Valganciclovir, ganciclovir drugs. And, rates are hard to determine. We have a very low rate in my program at Mass General, but rates have been reported in the sort of 5 to 12% after many organ transplants, and even higher up to a quarter or a third in intestinal and multivisceral organ transplant recipients. And one thing is that we've really seen low rates in things like the IMPACT trial of resistant virus. We were worried that when we went from 3 to 6 months of prophylaxis, we might see more resistance, but we did not. Next slide, please. This is information from Ajit Lemay's group, written up by Dr. Fisher at University of Washington, but they basically looked at who develops resistant CMV, and it's largely that high-risk D+R- cohort. When they presented with resistant virus, half of them had tissue invasive disease, so really a quite significant burden, and it's usually later after transplant with a lot more ganciclovir exposure, higher peak viral loads, and higher median, both mean and median peak viral loads. So yeah, that tends to be sicker and later after transplant and more immunocompromised. Next slide, please. And what they were able to show in their series is a significantly higher mortality rate in people that had ganciclovir resistant CMV. No surprise there. Next slide, please. So what is the definition of resistant refractory CMV? So resistant CMV is when you detect a genetic mutation that decreases susceptibility to one or more anti-CMV medications. Refractory CMV, and I really love this new working definition because we know that a lot of people may have resistant CMV infection, but it's not detected using our current assays, or it's clinically refractory. So this is when you have persistent signs and symptoms of CMV or persistent CMV viremia that fails to improve after at least 2 weeks. And remember that 2 weeks, never 1 week, 2 weeks of appropriately dosed antiviral therapy. So this is really something that's very helpful for me clinically. I hope it's helpful for all of you as well. Next slide, please. When you send resistance testing, it's important to make sure that you send the correct resistance testing. Previously, we were just sending UL 97 and UL 54, sometimes just 97 because 90% of the mutations occur there first, followed by 54. And now with Maribavir, you want to make sure you include UL 27 and UL 56 for Letemavir. So it depends what they've been exposed to as far as what you want to order. I would recommend ordering judiciously because this testing can be expensive. Next slide, please. So Maribavir is the new kid on the block, and in December of 2021, it was approved for treatment of resistant refractory CMV. It's not yet approved for any indication outside of resistant refractory CMV, and I will say that there's a phase 3 trial that just finished where basically it did not meet non-inferiority for preemptive therapy in asymptomatic stem cell transplant recipients, but it did have a sustained maintenance effects after the first 8 weeks of therapy. Nonetheless, it's not clear whether it will be approved for asymptomatic viremia treatment. And just to highlight, never use Maribavir for treatment if you are worried about encephalitis or retinitis, as it may not be adequately in that space, in those spaces. Next slide, please. So here's the phase 3 trial. Many of you could have seen this data, but it basically compared Maribavir with investigator-assigned therapy. Next slide, please. And here's the investigator-assigned therapy. You can see that, so it's basically standard of care. So the investigators decided what they would use. You can see about 40% were foscarnet and then a mix of various therapies. Next slide, please. The results were overall good, where at the end of treatment, after 8 weeks of treatment, almost 56% of those on Maribavir had cleared CMV versus 24% in those on investigator-assigned therapy. Unfortunately, off therapy, you can see in both populations that the rates of clearance, maintained clearance, and symptom control plummeted. Nonetheless, by week 20, Maribavir was still twice as good as investigator-assigned therapy, but still overall kind of disappointing from my perspective as a clinician. Next slide, please. Safety was very good. Dysgeusia is the main side effect of Maribavir. And then next slide, please. So overall, this was superior to investigator-assigned therapy for CMV viremia clearance with a good safety side effect profile. So overall, impressive outcome. Next slide, please. Just to highlight that there are significant drug interactions with Maribavir, and this was in a review article I wrote with our terrific transplant ID pharmacist, Ronak Gandhi. You can see that there are a lot of drug interactions to contemplate for both Cytomegalovirus and Maribavir. This is something new because with valganciclovir, we haven't had to think about drug interactions, but now we do. So I would recommend you just think cautiously and monitor your drugs appropriately. Next slide, please. So, next slide, please. So here's a case from my clinic that I wanted to just share with you as before I end. So this is a 68-year-old woman who underwent kidney transplant for IgA nephropathy. She was given antithymocyte globulin for induction, standard triple immunosuppression with tacrolimus, mycophenolate mofetil, and prednisone, and she was highly sensitized. She was in that high-risk group, D+ or minus. It was planned that we give her valganciclovir for 6 months. And shortly after the end of prophylaxis, she developed CMV DNA. We started her on treatment dose valganciclovir. We stopped her mycophenolate mofetil, and she had a very low absolute lymphocyte count at 160. So you know that this is a very high-risk situation. Next slide, please. And you can see here that the prophylaxis ends, and when her prophylaxis ended, her absolute lymphocyte count was very low, 180, and then she started in that second column from the left, you can see her DNA starts increasing. She had that classic February 15th increase at week 1 of 6,000 up from 1,000 DNA, and then she started falling, right? For a couple of weeks, the DNA fell, but then it started climbing. We tested for resistance. No resistance mutation was found. Next slide, please. And we then switched her, as per CMV guidelines, to intravenous ganciclovir, and her numbers continued to increase with a very, very low absolute lymphocyte count. We resequenced again and found the classic UL97 ganciclovir resistance mutation C603W, one of the canonical most common mutations, conveying high-level ganciclovir resistance. Next slide, please. So we switched her to Maribavir, and we stopped the ganciclovir and added acyclovir to prevent disseminated zoster, given that very low absolute lymphocyte count. And you can see that her, in that second column, that her DNA started falling with overall a good clinical response week after week. Although if you look at May 31st, you see that the DNA starts climbing again. We sequenced, and she was found to have the same UL97 mutation, but also a new H411Y Maribavir mutation. So, she was feeling great. Her absolute lymphocyte count was on its way up. I was sort of hemming and hawing as to what to do. But finally, she cleared, as I mentioned, with these low DNA emias, some people just clear on their own. She was a year out from transplant. And she cleared. So we stopped the Maribavir. I was thinking of putting her on Letemavir for prophylaxis, but it wasn't approved by her insurance company. And then fortunately, she just cleared virus and remained clear, as you would expect from her actually pretty robust absolute lymphocyte count. Next slide, please. You can see circled here that her absolute lymphocyte count really climbed when we weren't giving her a bone marrow suppressive agent. So I was impressed with that. Next slide, please. So the teaching points were that she had risk factors for resistant virus, age, antithymocyte globulin, low lymphocyte and neutrophil counts. And even with carefully dosed valganciclovir prophylaxis, we can still have issues with resistance. The low absolute lymphocyte count at the end of prophylaxis predicts risk of problematic CMV. So my big question is, should I have given her longer than 6 months of prophylaxis? Should I have used a different agent? Should I have done letemavir plus acyclovir? That's probably what I would do given the recent approval of letemavir in this high-risk D+R- kidney transplant setting. And then Maribavir helped clear the DNA emia, but there's still a risk of resistance developing. It did seem to allow the return of lymphocytes with no further bone marrow suppression. So overall, happy outcome. Next slide, please. In the CMV guidelines, we do have an excellent section by Sun-Wen Cho where he goes through the various management guidelines. And then we actually updated this to this clinical decision support tool for CMV that we made that includes guidance on the best use of Maribavir. So I hope you find that helpful. Next slide, please. And thanks a lot, and on to the next speaker.
Great. Thank you so much, Dr. Cotton. I appreciate it. And just before I do introduce the next speakers, just a reminder to the audience to use the Q&A button to ask questions at any point. Now I have the pleasure of introducing two individuals who will shed light on the crucial role of caregiving for post-transplant patients. Their expertise and insights will greatly contribute to our understanding of this vital aspect of patient care. First, Lauren Tokarwich is the National Alliance for Caregivers Senior Manager of Special Projects. Her role requires developing and managing the projects that focus on specific conditions of care recipients or populations of family caregivers. She is also responsible for conducting the oral histories NAC uses to collect caregiver stories to impart, on a more personal level, the caregiver experience. Lauren has co-authored the Circle of Care Guidebook for caregivers of rare and/or serious illnesses and caregiving in a diverse America, beginning to understand the systemic challenges facing family caregivers, as well as authoring Supporting Diverse Family Caregivers, a guide for patient advocacy groups. Currently, she is working on projects that focus on the needs of transplant caregivers in the U.S. and on advancing the mental well-being of family caregivers. Lauren has a Master of Library and Information Science from the University of Illinois, Urbana-Champaign, as well as a BA in History and English from the same university. She has previously held the Research Manager and Special Projects Associate role at the National Alliance for Caregiving. Joining Lauren is a caregiver, Mr. Ira Copperman. Ira has participated in the organ donation and transplant world for more than 20 years, before his spouse, Glenda, received a simultaneous kidney pancreas transplant in June 1999. Ira first participated in public-oriented events at speaking and organ donor registration activities. He joined the Transplant Support Organization, TSO, a patient-centered transplant group in Westchester County. He currently serves as president of TSO and is the TSO representative to the New York Center for Kidney Transplantation, as well as a member of the Regulatory and Practice Committee and the Public Education and Practice Committee at NY Kidney. Ira is involved at the national and local level for transplant recipients. Nationally, he works with the Partnership for Part D Access and the NASH Alliance. Locally, he leads efforts on behalf of the National Coalition for Transplant Equity and is a member of the Medical Advisory Board of Live on New York. IRA serves as a civilian reviewer for the Department of Defense congressionally directed medical research programs. IRA and Glenda regularly attend UNOS Region 9 meetings and Region 9 transplant collaborative meetings to gain a better understanding of the medical issues that arise in transplantation. IRA and Glenda attend symposiums at local transplant centers to grow their information base in the transplantation field, and they are members of TRIO Manhattan, a patient-centered support group located in New York City. IRA is a regular participant in the webinar training program provided by the Organ Donation Alliance. Lauren and Ira, we're looking forward to hearing from you.
Thank you.
Hi, I just wanted to start by thanking the IDSA Foundation for having me and for inviting me to speak on such an important topic. As was just said, my name is Lauren Jakarwich, and I'm the Senior Manager of Special Projects at the National Alliance for Caregiving. The National Alliance for Caregiving is a nonprofit dedicated to improving the lives of family caregivers through research, innovation, and policy change. We want to help caregivers across the lifespan, caring for those of any condition and of any age. For more than a year, we have been working on a project dedicated to improving the lives of transplant caregivers. Our sponsor, Takeda Pharmaceuticals, was interested to know whether or not family caregivers of transplant recipients were receiving support post-transplant, and if not, what could be done so that they are better supported. Since the majority of transplant centers require a caregiver to be identified in order for someone to receive a transplant, they are vital to the process and the care of the recipient. Our project included a literature review to explore the current state of transplant caregiving, conversations with transplant professionals such as providers, patient advocacy groups, and transplant coordinators, and focus groups and one-on-one conversations with transplant caregivers themselves. Through this work, we've gathered a wealth of information, not only on how integral caregivers are to the transplant process, but also on how little they are supported. We have learned several important things throughout our research. First is how much of a partnership there is in the relationship between a transplant caregiver and their recipient. Although many caregiver and recipient relationships tend to be partners in the decision-making process, we found through speaking with the transplant community that caregiver and transplant recipient relationships are much more dyadic. They feed off of one another's energy, and the health of one can affect the health of the other. When a recipient is going through a difficult time, the caregiver can become more stressed and anxious, resulting in poor mental, emotional, and even physical health for the caregiver. When the caregiver is then in poor health, it becomes difficult for them to care for their recipient, causing the recipient to become even more ill. Supporting a caregiver through these times and easing the stress they feel can mean better health for both the caregiver and the care recipient. Secondly, we've learned that information and education, both pre and post-transplant, are vital to the success of the caregiver and the recipient. When caregivers do not know how to perform medical tasks, or do not understand how medications interact and what they do, or do not know how to provide meals that adhere to necessary dietary restrictions, their role becomes much harder as they often have to spend time looking for the information themselves. Many times, a caregiver does not know what they don't know, leading to more stress and confusion. A mindset that can be unique to transplant caregivers and their recipients is that they can be under the impression that life will go back to normal post-transplant. Caregivers can be unprepared when this is not the case. It is especially important that caregivers are educated on possibilities such as post-transplant CMV, and that they understand what can be done to lower the chance of infection, or what their caregiver role will look like if the recipient is diagnosed with CMV. Unfortunately, we have found that there is no standard practice across transplant centers for providing caregivers with education and support. But both education and support are needed in order for transplant recipients and their caregivers to live their best lives. As noted by the United Network for Organ Sharing, transplant caregivers are key to transplant success. These caregivers are there for medical tasks, to support the recipient's recovery and their mental, emotional, and physical well-being, to assist them in their new medication regime, and to join them in their new diet and way of life. They are there for the recipient when they undergo surgery to receive their transplant, and they are there in the hospital for the following days, weeks, or months of recovery time. They speak with doctors, nurses, coordinators, learn medical lingo, and read up on everything there is to know about transplant. They help with or entirely plan the logistics of getting to the transplant center that has the needed organ, whether it be in the same city or across the country. They experience the heartbreak and grief of a dry run or a non-viable organ, and they juggle the financial aspect of the transplant process. from paying for parking in the hospital lot to dealing with insurance policies. Transplant caregivers are there for their care recipients. From our research, we know that they are of immeasurable value to the entirety of the transplant process, the healthcare system, and those they care for. That's why we believe it's extremely important that the system at large is able to provide them proper training, in-depth information, and much needed support in their roles. I'm now very pleased to introduce you to my friend Ira Copperman, who has been an important part of the project as an advisory committee member, as an expert source of information, and as a transplant care partner sharing his experience. Please take it away, Ira.
Thank you very much, Lauren, and thank you to the IDSA for letting me have this opportunity. I'll just start by saying that Gwen and I have been in the care partnering business together for about 44 years. So we've had a lot of experience with this process. 20 years prior to Glenda receiving a simultaneous kidney pancreas transplant, and 24 years since Glenda received that transplant back in 1999. So very, very early on, I found out that if I wanted to be a successful life partner for Glenda, that I better start a journey of education on exactly what was going on. We did that. We did that together. We were very, very lucky to have doctors who would tolerate my coming into the office with Glenda for all of her medical visits, and I think it's safe to say that we did that together. 99% of the time that Glenda went to see a doctor, I was able to tag along, and very, very warmly received by the staff. That practice of keeping up with what was going on continued post-transplant and continues to this day. Specifically interesting was Glenda's experience with CMV. Glenda began her course of immunosuppression, of course, the day of her transplant surgery, and it included Prograf and Cellcept and prednisone at high doses. 3 years into it, she changed out of Cellcept because of some side effects to sirolimus, and that continues to today that she's been on. And over time, we've been able to decrease those doses. About a couple of days before Glenda left the hospital, her doctor, post-transplant support, came in and said, well, now let's talk about your treatment for CMV. And we said to him something like, well, wait a minute, Glenda's already had her measles vaccination. What are you talking about? And of course, then he took the time to educate us on this process. It became early on that Glenda was not going to be able to tolerate the usual application of Valsite. I'm sorry, I got tongue-tied with Valganciclovir, but Valsite. So we went to the HIV/AIDS nebulizer labs for her treatments that lasted for, as best we can remember, every week for about 6 months, somewhere in the 3 to 6 month range. And that continued even through those early months of high immunosuppression. Obviously, as the immunosuppression has been reduced over time, very, very successfully, I might add, we have found that in 20 plus years since that initial beginning of high treatments for CMV, Glenda has never had a CMV infection that to speak of. So that early part of getting educated, finding out what we had to do, finding out very quickly that there were some things that weren't going to work and other things that would work, really, we think has served us very well. It gave us a lesson for the future. Every time an incident would come up, this early incident with CMV treatment just gave us the way we would approach treatment options, various times during the year, all the time, to be educated about it, to understand as best we can what the doctor was talking about, and then proceed together along this path, which which I'm very happy, as a very, very happy spouse, to be able to say that that's the way it's been for 24 years. So again, thank you. We could not have done it without an incredibly important post-transplant team of doctors and follow-up staff. And we've just had a very, very lucky and fortunate journey. So again, thank you to the IDSA for this. Thank you to Lauren for inviting me to be the person to represent the caregiver care partner side of this equation. And Lauren, thank you very much.
All right, thank you. I'll hand it back to you, Diane.
Great. Thank you so much, Lauren. And thank you, Ira. That was just incredible. I'd just like to invite both doctors to come back on screen. I know that Dr. Cotton has an announcement she'd like to make. I think that they have both answered most of the questions that were in the Q&A. There's one left that they will say now, and if there's anybody else that has anything to add. So although this webinar was to go to 2, we may go just a little bit over, so maybe 2:05. So if you would just kind of hang in there and bear with us, we'll get through everything. Dr. Cotton?
Thanks a lot. I just wanted to say that if you liked the topic of this webinar, we actually, and if you're interested in infectious disease, we actually have a fellow spot open at Massachusetts General Hospital and Brigham and Women's Hospital starting July 1st. So if anybody doesn't have summer plans and would love to do more of this type of work with us, you can contact me directly, or if you can contact the organizers of this and they can put us in touch. But we'd be happy to have people who are interested in applying for infectious disease fellowship, which I have to say, both Mike Eisen and I would agree. We love our careers. We really, every single day, I love what I do. I've done it for over 20 years, and I can't imagine doing anything better. And just so rewarding, wonderful, and personally, I'm just so happy with my career choice. Anyway, Mike's going to go on and answer a CMV question. We're happy to have more questions in the chat.
Yeah, looks like there's two questions. I thought the first one, since they asked what we did, universal prophylaxis or preemptive. At Northwestern, we are still using universal prophylaxis, as I said, because we found that we had difficulty implementing preemptive monitoring, but there are centers that are able to do that quite easily. How about you, Camille?
Yeah, we do. We always have used prophylaxis. We just find it easier, especially during the pandemic. It was actually hard to get CMV viral loads done. So we've always done prophylaxis. Although I think that when we run into trouble, I will then use preemptive therapy. One of the companies that was supporting a patient assistance program for valganciclovir is no longer doing that as of the beginning of January. So cost is a real issue. These drugs are very expensive, including the newer agents are that much more expensive. So then I'll use preemptive therapy when necessary. But in the guidelines, we really say that we can go back and forth between preemptive therapy and prophylaxis. And there's actually a great paper that was just published in Transplantation by Blom, B-L-O-M et al. In Norway. And they actually used the Norwegian database for the better part of the past 20 years, comparing prophylaxis with preemptive therapy, and overall outcomes are the same. So I feel really comfortable with that.
So there are 2 more questions, open questions.
So maybe the second one first, high dose acyclovir. So there were some studies early on before valganciclovir was available. The challenge is you typically have to use a relatively high dose. I think it's 2 grams a couple times a day, which is difficult for patients oftentimes to tolerate. And I think I would personally favor either preemptive monitoring or valganciclovir. If they weren't able to tolerate it, then letermovir over high dose acyclovir.
And how about this one? Can you comment on experience with Maribavir used as secondary prophylaxis after resistant refractory CMV? And, I have not done that. It is not recommended for prophylaxis. We are seeing some rates of resistant virus. So what I do for resistant virus, if it's a very high DNA emia, I'll actually use foscarnet for induction, followed by Maribavir. And then for prophylaxis, I'll use letemavir. So I hope that is helpful.
I will say we did use it when we felt secondary prophylaxis was needed, just because patient assistance was oftentimes easier for us to get the Maribavir and basically continue it on, and then we would monitor them very closely.
Yeah, I would agree with that. I think it's all about what you can get for your patient.
Yeah.
There's a question about why do you sometimes have negative blood tests, but colonic biopsy or vitreous aspirate be positive? And it does seem like there are some types of preserved spaces where you can have negative bloodstream infections, but end organ positive disease. Mostly clinically, honestly, mostly that's seen with GI disease. And we're seeing a lot less now that we have these ultrasensitive assays. I recently said I haven't seen it in a couple of years, and lo and behold, the following week I saw a case of it, GI disease, but it's pretty rare with the ultrasensitive assays, but it is something to definitely know about.
I guess the question is, with those ultrasensitive assays, are we sure that it's CMV colitis in all of the cases?
Very good point, Mike. Yeah, sometimes you even find CMV on colonic biopsies, and it's not always straightforward as to what you found.
And the reason I ask is that at least our practice at Northwestern before I left was we weren't doing a lot of colonoscopies like we were early on. If we saw the CMV, we'd just presume colitis and treat it. And so I especially as we've moved down to these super sensitive tests that I personally don't know, what 37 copies means other than to watch the patient serially over time in most cases.
And I'm getting a question about at what threshold do we initiate treatment? And we actually do cover this in the guidelines. And I don't think that there are any major updates to what that section of the guidelines said, but basically if someone is seropositive, you can probably use a higher threshold for initiating therapy. So somewhere, it depends if it's whole blood or plasma, it depends which assay you're using. But somewhere kind of in the neighborhood of 2,500 to 3,000 is often used for seropositive recipients, but the D+R- population would be a much lower threshold because those are the ones that could have explosive disease. And so unfortunately, we wish we had thresholds for you. We've wanted that with every version of the guidelines, but because as Mike nicely covered, the variations that we see with specimen types and platforms, we can't really have standard platforms.
Okay, great. I think it looks like we have covered the questions that have been asked. So again, thank you to all of our esteemed speakers. Thank you also to the audience and for your participation. As I said early on, if you wish to revisit this webinar and share it with others, the recorded session will be made available on our website and YouTube channel. We hope you found today's program, sponsored by our industry partner Takeda, to be very informative. And so now, if you'd like to follow us, we certainly encourage you to follow us on our social media channels. If you have any interest in becoming, if you are not already, a member of the Infectious Diseases Society of America, please feel free to reach out to us or visit the IDSA website for more information. I'd be remiss if I didn't tell you to mark your calendars for ID Week, which is taking place in Boston, October 11 to 15. Registration is now open for members and non-members. The John G. Bartlett Memorial Education Series is a non-CME webinar series that explores a wide range of disease states. Be sure to sign up for our newsletter, ID Insights, and join us again for additional programs coming this fall. Lastly, we kindly request your consideration in supporting the IDSA Foundation through a donation. Your contribution plays a vital role in advancing workforce development, providing research grants, and educating healthcare professionals. Again, thank you so much for your participation and have a wonderful rest of your day.